X-rays are one of the least understood elements of dentistry, both by patients and even some staff members. Yet they're one of the most useful diagnostic tools the doctor has. Much like airline pilots use radar to see in the clouds and in the dark, X-rays allow us to see inside the teeth and bone structures, identify disease, and evaluate healing. Exposing and developing X-rays may well be one of your most valuable contributions as a dental assistant because of the importance of X-rays in proper diagnosis. In addition, X-raying patients is the only dental procedure that you do that is absolutely irreversible. That alone tells its importance, and we'll discuss the risks that accompany X-ray use in just a minute. Before we continue, for simplicity's sake, please notice that we'll use the term X-ray to include the radiation, the process, the films, and other aspects interchangeably. In order to be able to properly use X-ray in treating patients, we must have some idea of what it is and how it works. The best way to create these ideas is to have you think of a flashlight beam. X-rays behave very much like light rays, but with some obvious variations, like being able to penetrate solid substances. They have many great properties that enable them to do their job of letting us see within. Again, the bad news is that every time we expose someone to X-ray, tissue undergoes some degree of injury, albeit minor and reversible. It's the trade-off to be able to prevent or help heal them from disease. About the only thing that absolutely stops X-rays is lead. One testament to the low levels of X-ray that we use in dentistry is that the walls and the doors of our rooms need not be lead-lined. In fact, the doors are not even required. You can share these facts with apprehensive patients to help allay their fears. The energy is absorbed by the body, and it causes some degree of injury with every exposure. The body, though, through many of its wonderful processes, is able to heal the injury. It's our duty to minimize the X-rays through proper technique, using film holders, fast films, lead aprons, and when the benefits outweigh the risks, X-ray use, in spite of its drawbacks, is perfectly acceptable. So we've said that X-rays behave a lot like visible light. When you compare and contrast the two, you gain a rather firm grasp of X-ray, film, and tooth interaction. It's on understanding this interaction that proper technique rests. In these examples, using an overhead projector as the X-ray, a toothbrush as a tooth, and the board as the film, notice how modifying distances affects the ruler's shadow as it's cast on the board, and liken this to a tooth whose shadow would be cast on an X-ray film. The closer the toothbrush is to the board, the crisper the shadow. The closer the toothbrush to the light, the blurrier the shadow, and plus it gets magnified even more. This tells us two goals we want to keep in mind when we make great X-rays. Number one, keep the film as close to the teeth as you can. And number two, use the longest X-ray tube or positioning device to help keep the X-ray source as far away from the teeth as possible. Now notice what happens if the ruler is tilted. When we mark the shadow length when it's straight up and down, and then mark it again after it's tilted, notice how much shorter the shadow is. This problem in dentistry is called foreshortening, and occurs if the film and the tooth are not as parallel as possible. It can fool the X-ray film viewer into thinking that the teeth are shorter than they really are. Finally, pretend that the square drawn on the board is the X-ray film. The ruler is the tooth. As the light source is moved sideways, diverted from hitting the film dead on at 90 degrees, notice how the tooth moves off the film. So hitting the film at a right angle helps assure us that the tooth's shadow will be present and centered on the dental film. In brief summary, number one, keep the film and the teeth as close together as you can. and the X-ray source as far back as possible. Number 2, make sure that the teeth in the film are parallel in both planes, up and down and side to side. And number 3, make sure that the X-ray hits the film head-on at 90 degrees. Naturally, obvious requirements like centering the tooth over the film and covering the film completely with X-ray aren't mentioned. Success with these relies on your knowledge of dental anatomy and the use of aiming devices, which we'll discuss in just a few minutes. There are basically two types of X-ray films made in dentistry: small films that are used intraorally, and larger extraoral films like the panoral film. Intraoral films are sized according to the need or patient demands. The smallest sizes, like the 0 and the number 1 films shown, are used in X-raying children's teeth and the smaller front teeth of adults. The size 2 film is used for X-raying the back teeth of adults and for cavity-disclosing bite wings. Size 4, the largest film used inside the mouth, captures the entire arch of adult teeth in an occlusal view. Small children's occlusal views are done with a size 2 film. Extraoral dental X-ray films used in general practice are mostly the panoral or panorex films. The panoral X-ray machine circumnavigates the head and renders a flat image of the upper and the lower jaws onto a single rectangular film. Dental specialists like orthodontists and oral surgeons also use cephalometric films, which allow for a side view of the head, the jaws, or the TMJ. X-ray films should be properly stored in a cool, dry area until they're used. Refrigeration is ideal but not mandatory. Just remember to warm the films to room temperature before you use them. All films should be labeled after use. Panoral films must have the left and the right sides properly marked, which is often done automatically by the X-ray machine. Plus the date and the patient's name must also be attached. Small intraoral films are placed in mounts and then labeled in much the same way. There is an exception, though. The small intraoral films have no left and right orientations. Instead, a raised dot lets you know you're looking at the film from the proper side. The American Dental Association standard says to mount and to view the intraoral films with the dot facing you. This mimics looking at the patient face-on when viewing the mounted films. However, follow your doctor's guide and base the film mountings on his training and habits, since he has to read the films. The entire process of making dental X-ray films involves using 4 groups of equipment: the X-ray machine, the X-ray film, film holders, and developing chemicals. The number of steps throughout seems infinite, each blending with the next. It's very important to remember, though, that the most important step during the X-ray process is the very step you're doing now. A seemingly minor error at any step of the process may render a film unusable. And if an X-ray must be repeated, who suffers? The patient does. The X-ray machine consists of a control panel and the tube head. Intraoral machine tube heads are widely movable. A panoral machine's tube head moves in a circular arc around the patient's head. The tube head has an aluminum lead-lined tubular positioning device, sometimes incorrectly called a cone, that shields out the weak scatter radiation. It restricts the useful 2 3/4 inch beam of the intraoral X-rays to the film. The control panels in most X-ray machines are very similar. You'll see some minor variations, some being fully automatic, to those that allow adjusting the kilovoltage, which manipulates the penetrating power of the X-rays, and adjustment of the milliamperage, which regulates the total number of the X-rays. Naturally, increasing either one, the penetrating power or the number of X-rays, darkens the image. All X-ray machines are required to have an electronic timer that allows fraction of a second exposure times. The exposure button may be attached to the control panel by a cord, or it may be mounted on a wall away from the machine. It must allow you to get out of the direct or primary X-ray beam, placing you behind it and more than 6 feet away from the tube head. With these conditions met, you're safe from exposure. Intraoral X-ray film comes in 2 speeds. With the ultrafast E-speed film now as economical and crisp as D-speed, while exposing patients to half as much radiation, there's no real reason to continue using the older D-speed films anymore. Some dental practices are using computerized X-ray imaging, in which no film or processing is needed. The X-ray image appears on a computer screen. Aside from the high initial expense in its use, there are very few drawbacks to its use. Proper X-ray exposure demands exacting techniques. Retakes are not acceptable substitutes for proper technique. In order to ensure capturing a diagnostic image on film, film holders are used. It is not acceptable for you to hold a film in any patient's mouth during an X-ray exposure, and you should also not ask a patient to do it. Their untrained hand is prone to error, which can result in missed films and retakes. And who suffers? The patient. Film holders can include the RIN XCP, the snap array, and even hemostats for periapical views during root canal therapy. Each film holder type has its own place. Bite wing films are positioned using the RIN appliance, or more commonly peel and stick foam or cardboard sleeve film tabs. Using these tabs demands advanced radiographic skills, since the film disappears into the mouth with nothing to aim the tube toward. You must have a great knowledge of dental anatomy to avoid cone cuts, overlaps, and other errors that we'll discuss at the end of this film. Finally, processing the X-ray films completes the process. Modern automatic processors eliminate a lot of errors and guesswork, replaced by a critical demand for machine maintenance. Hand processing using the dip tank or chairside developers still has its place and will be discussed shortly. There are 4 basic rules in capturing an X-ray image of the teeth on the film. These rules cannot be repeated too many times. First, the film and the teeth should be as parallel as possible in both planes. This is never absolute, just a goal. The portion of a film further away from the teeth means that a blurrier and slightly enlarged image will appear. In both planes, horizontal and vertical, try to keep the film in line with the teeth. Second, the film should be as close to the teeth as you can get it. This minimizes magnification and blurring. When you forget, simply use your hand to project a shadow and move it in and out from the surface as a reminder. Third, the X-ray beam must hit the film and the teeth head-on, 90 degrees, at a right angle. If you hold your fingers as if they were teeth in front of you, joined together and side by side, and then slowly rotate your hand, you'll notice that the fingers overlap as the spaces between them close. If your eyesight is the X-ray, the scene is becoming distorted. This is demonstrating overlap. Pay attention to placing the tube head flat on the ring. Finally, the teeth must be centered in the beam to avoid a cone cut error. Otherwise, a retake will be required, and who suffers? The patient suffers. All of these errors will be demonstrated at the end of this film.